Hi, thank you, Judy, for that introduction. We are going to be playing Kahoot, so if you haven't already logged in and given yourself a name, please do so. And I'll just give you guys a minute or two to do that. And I think we have a test question. Okay. Anne Fleetwood was going to help me toggle between Kahoot and PowerPoint. She must be chit-chatting. Means you guys have more time to sign into Kahoot. I see her. Okay, in the meantime, we'll start with slides, and then when Anne comes in, we can do a test question and make sure everybody understands how to play, and then I think we have time in my slides before the first Kahoot takes place. So, you're not able to switch it either. All right, so we can get started on the slides and we'll break back to Kahoot in a few minutes. So like Judy said, my name's Beth Tressler. I'm a pharmacist at YKHC in Bethel, Alaska, and today we're going to be talking a little bit about YKHC's prescription produce program, but more so about how can you start thinking about a prescription produce program. I have nothing to disclose. A few objectives that we're going to try to hit are defining a produce prescription program, identifying potential funding sources, for you to be able to describe programmatic details of a produce prescription program, and then identify steps for starting a new program. So what is a prescription produce program? It's a health intervention for patients who are eligible due to health risk or diet-related diagnosis, lack of access to nutritious foods, and are referred by a healthcare provider or health insurance plan. These prescriptions are fulfilled through food retail and enable patients to access produce with no added fats, sugars, or salt at low or no cost to the patient. When appropriately dosed, produce prescription programs are designed to improve healthcare outcomes, optimize medical spending, and increase patient engagement and satisfaction. This is our first Kahoot. Are you ready? Time for a quiz. First question, are you ready to play Kahoot? Please answer. You have to pick a color on your phone. And I think it gives you about 30 seconds. You've got 2 seconds to get your answer in. Woohoo! We got 15 people that are ready to play Kahoot. And or a few that are ready. All right. You know how to play. Next slide. So what do you think about when you hear diet-related health condition? This is a word cloud, so you can type whatever comes to mind. Okay, some good answers. So sounds like diabetes comes to mind a lot when you hear diet-related health condition, obesity as well, which makes sense, especially after Dr. Naylor's presentation this morning. Bland comes up, probably thinking about the term or the word diet. Poor nutrition comes to mind, which I think is great too. So good answers, and thank you for participating. Next question. What percentage of the population you serve would you estimate experiences a diet-related health condition? I forgot, on your phone I think you only see the colors and not the choices, so if you want me to read what the colors are, let me know. So the majority of you said 50 to 75% of your patient population experiences a diet-related health condition. That's a lot of people. Several people also answered more than 75%. That's huge, right? So that means that a large portion of the population that you serve, that you provide care for, is struggling with a diet-related health condition. Next question. What percent of the population that you serve experiences food insecurity about half of the time or more than half of the time? So now we're thinking about diet-related health condition and also food insecurity. And the survey says 25 to 50% was the majority of the answer of people in your population experience food insecurity more than half the time. More than half the time. Some of you did say, I'm not sure, and that's okay. Nobody answered, we don't screen for food insecurity, so that's an interesting non-answered response. I think there's one more question in this one. Yes. What challenges do you hear when discussing access to nutritious foods? This is also a word cloud, so you can answer whatever you want. So when you're talking to your patients and talking to them about, we probably don't say what they should eat, but what we would advise to eat or what would be more healthful options. What do you hear back from your patients or customer owners that you serve? Too expensive, cost, foods not available, few choices, don't like vegetables. That's so heartbreaking. I'm not even a dietitian, and I find that heartbreaking as a pharmacist. Or too poor to access. And this is huge. I think this should resonate with all of us, and I think is really applicable. Thank you guys for participating in these questions, because this is stuff to keep in mind as we move forward with this talk. I think I'm ready for the next slide. Let's do a question and see what happens. Okay, we'll do this one. Is fresh produce available year-round in the communities that you serve? No. No. How are we answering this question with no? How is there not produce available for people to eat? So now we've identified that people are suffering from diet-related health conditions. People are experiencing food insecurity more than half the time. And then to compound that, there isn't fresh produce available. Just think about that. Let's do a slide. Yep. Okay. Some data that I wanted to share with you, and it's similar information but different than what Dr. Naylor presented on this morning. So I wanted you to be able to compare and contrast the United States to Alaska in terms of overall food security. So you can see that over 33 million people in the United States experience food insecurity, which equates to 10.4% of the United States population. In Alaska, 78,000 people experience food insecurity, which equates to a rate of 10.7%, which is slightly more. This slide shows you that the average meal in the rest of the United States costs $3.59, with Alaska's cost being about $425. And I'm sure if that information were available in the smaller areas and broken down more, I think we'd see even larger disparities in how much food costs in our state. Something else I want to draw your attention to is the green pie for Alaska. So if you compare the pie for the United States and then you compare the pie for Alaska, you'll see the darker percentage shows that 40% of Alaskans are below the SNAP threshold of 130% poverty rate. 40%. And 60% are above the threshold, but still qualify for SNAP. Whereas in the rest of the United States, 32% of the population is above that SNAP threshold. Again, something to think about. So looking at Alaska a little bit more in detail, you can actually find this information on the internet from Feeding America. And this will actually break down the state by region, so you can get your own region-specific data if you're curious what food insecurity rates look like. But what you see is that it really is across the state. There are huge food security and food insecurity challenges. So in Southwest Alaska, I work at YKHC, and so we serve all of Southwest Alaska, which is a landmass the size of the state of Washington. But one of our census areas is the Kosovac Borough, which has a 25.9% rate of food insecurity. And 100% of those people are below the poverty threshold of 130%. Not 50%, not 90%, 100% in that region is below the SNAP threshold of poverty. So we knew this at YK. We knew this for a long time. We heard all the things that you guys reported in the word cloud, that there isn't access to it, there's not fresh produce available, and our team was left trying to figure out, well, how do we provide education and guide people to making healthier choices when they're telling us that there's nothing available? So we wanted to do something about it. And a few years ago, we had some extra money and we had a partner that was willing to work with us and wanted to try to improve on this. So we started a program where people could send us a request weekly and ask for a box of fresh produce. I didn't include the statistics in my presentation today. Maybe it would have been helpful, but, and I can share that information with any of you if you'd like it later. But we gave out hundreds of boxes and reached hundreds of people, and people were so thankful and so appreciative and really just appreciated the opportunity to have fresh produce and then to have it at an affordable amount, which was at that time nothing, was just huge for families, for communities, for children. And so given this data and given our kind of pilot project, we knew that we wanted to do something about it and that we needed to figure out how. So it turns out there's actually funding sources for prescription produce programs. There's even funding sources that target rural prescription produce programs. There's a few different types of funding sources, and there's a website that you can go to that will guide you to this information. There's several foundations and nonprofit organizations that you can explore. And I actually just got an email on like Tuesday of last week from the American Heart Association that they're offering funding for a prescription produce program. And it has a pretty good window of time to apply. So if you're thinking about it, please look at that one soon. There's also several funding sources through government agencies. So YKHC currently has three grants. They're all through the USDA and the Gus Schumacher Nutrition Incentive Program. That was first offered for application in 2019, and we were first awarded funding in September of 2019 through the Gus Schumacher Nutrition Incentive Program. They offer funding periodically and will announce notices of funding opportunities, so keep an ear out for those too. And there's a huge network of resources for support through that one. The CDC has multiple grants that they will put out, and then the Indian Health Service has actually started doing something too. So I listed their prescription produce pilot program, which was a grant application that was open through June, and it was approximately $2.5 million that they intended to award, and people could apply for up to $500,000 worth of funding. They had, I think I heard over, I want to say 80 applicants, and so with only $2.5 million, that wasn't going to make it very far, and they did award 5 programs. There were multiple applicants from Alaska, but unfortunately none of the Alaskan applicants were awarded. I'm told there could be more funding available in the future, and so keep thinking about that one too. And then, of course, how we first embarked on a prescription produce program was through our SDPI funds. And so if you have extra money, or if you are thinking about how to write your grant application for next year, thinking about including some way to fund prescription produce might be something to write into that application. And then I found this interesting, that some programs might be able to fund produce through sugar-sweetened beverage taxes. I find it interesting because several years ago, the city of Bethel explored the idea of implementing a sugar-sweetened beverage tax, and we were met with a lot of resistance, including big corporations were infiltrating Alaska and trying to stop this tax from being implemented. And lo and behold, they won out, and we do not have a sugar-sweetened beverage tax in Bethel. But in theory, there could be some funding if you can convince your local government to implement a sugar-sweetened beverage tax. Then what do you do with that tax? Maybe it could promote healthier eating. So if you're thinking about implementing a prescription produce program, you've got to think about budget. And the budget generally revolves a lot around the produce incentive costs, which makes sense, right? The whole purpose of the program is to provide people with produce being the incentive. The budget, so things that you want to incorporate in your budget are going to be the cost of the incentives, staff and personnel time, materials that you might need to execute the program, such as vouchers, paper to print the vouchers on, how you're going to recruit participants, because that can have cost with it, postage if needed, and any technology needs. And then program evaluation is another thing to think about when creating your budget. So in thinking about produce incentive costs, it's going to depend on how many people you're wanting to enroll in your program. So yeah, our YK's population is about 30,000, and so I made a target for you to think about this in. The entire population is 30,000. Let's just say we had $30,000 to spend on prescription produce. We wouldn't be able to target the entire population because you couldn't give 30,000 people $1 worth of produce one time and have it have any effect. So you want to think about then how can you drill that down. And with our funding source, the Gus Schumacher Nutrition Incentive Program, one of the requirements is that they have to be Medicaid eligible or receive SNAP. That's a given. We have to include people that are within that population. And so then that's still a large portion of our population. Obviously, we talked about the food security rates and SNAP population. So then, because it's prescription produce, that means that we're targeting a diet-related disease. And so that helped us narrow down our patient population. Naturally, our main funding source is the SDPI, or Special Diabetes Program for Indians grant, and so we wanted to target people with diabetes, and that is our target population, and that helped to narrow the numbers down. But you also need to factor in program duration and how long you either have to spend the funding or how long you're able to operate the program. And then details of the prescription also factor into that. So like I said, if you had 30,000 people, you couldn't give them $1 one time. You would give them a certain dose, incorporate the route because it's a prescription, the frequency, so how often do you want them to be able to redeem their prescription, and then how many times are they able to refill their prescription. So just to give you an example and really show that it is a prescription produce program, I shared a sample of what our prescriptions look like, and we do use Cerner. And so we actually write a prescription in the electronic health record, and then it shows that 3 can be dispensed, and there's 4 refills, and then the SIG is how to redeem the prescription for produce. So that prescription then gets translated into a voucher, and we provide our participants with vouchers. Our dose is $45, so participants get a voucher for $45 worth of produce. Then they can use that $45. They get 3 at a time, so they get like a 90-day supply for their prescription. And then they're dated, so they have 1 month to use each of the 3 vouchers. So 1 month for January, 1 for February, and 1 for March. And then our voucher includes information for what they can purchase with that voucher, which in our area we're able to offer fresh, frozen, or canned fruits and vegetables, which is also super important because like we all identified, majority of the year there isn't fresh produce available, and we heard that a lot from people. So we've tried to figure out, what can we offer, and we include that on the label. You might notice too that it says for the purchase of WIC approved, and so we put that on there in an attempt to help guide the store clerks to what would be an appropriate purchase, because they're very familiar with what is a WIC approved item. The shelves are all labeled WIC approved, and it was a way to help guide appropriate purchases. So still thinking about budget and the staff and personnel time associated with the budget. So you're going to need somebody to help run the program. And in general, this would be a program coordinator. This person's going to be responsible for program implementation, building partnerships, program training, potentially incentive distribution, and then grant writing and reporting. So if you are a grant-funded program, there's going to be reporting that's involved, and knowing that somebody is going to have to be available and budgeting time for that is very important. There's going to need to be somebody that can cover the program operations and do general administrative duties. And then you might want to think about if you need to budget in costs for any community-based partners. And I'm going to get into more about partners here in a little bit. Also with budget is materials and supply costs. So we talked about voucher methods. And the really cool thing about prescription produce programs is that they can be totally unique and totally oriented to meet the needs of your community. For us, it was paper vouchers, and then we mail them out quarterly. But that is included in the cost, is mailing them and actually having the paper and the creation of the vouchers. Program advertisements, so we need to make sure that people are aware of the program and we can get this information out there, and naturally there's budget associated with that. The voucher distribution I talked about, and then overhead. So thinking about if there's computer needs or cell phones, possibly transportation costs, etc. And briefly on program evaluation costs. So with any program, you want to be able to evaluate and measure success. So what does that look like? Again, can be very unique based on either your funding source or what kind of information you want to gather from the program. So there's survey creation that's involved in that process, and thinking about that with your budget is important too. You may need to also incorporate IRB, Internal Review Board, Investigational Review Board, into that, which we did have to have our protocol approved by an IRB. And then if you're able to or interested in trying to offer incentives for people to complete surveys, you may want to budget something for that too. So moving on to partnerships. Partnerships are really key to a successful prescription produce program. And figuring out where you can make partners and who's already in your community is a really instrumental thing in making this program happen. So what do you have in your community? Is there a food bank that's already operating and has a monthly schedule for handing out food? Are there church organizations that coordinate and organize food collections? Are there school programs? Is there FDPIR? Is there SNAP? Is there WIC, which SNAP and WIC I think is a given? And also thinking about healthcare resources. So some prescription produce programs are operated by a healthcare organization, which ours is. There's a lot that aren't. And so if you're doing it not from a healthcare organization, having a healthcare organization that you can partner with is extremely useful and paramount if you're writing prescriptions. And then also thinking about what stores are in your communities. So what grocery stores, what are they like? Who are the wholesalers for those grocery stores? What are the food vendors that might already be shipping into your community? Does Cisco ship? Does Di Tommaso ship? Where can you access foods to bring into the community? And then also community gardens. I think that's something that we don't necessarily think about a lot, but I know if you ask the questions, more communities than you might realize actually do have community gardens. And so if you can either leverage use of the community garden or find a way to just tap into that or help increase the reach of the community garden, you can use that for a partnership. And some of the partnerships that we have forged in order to make our program work are the stores, the vendors. We have not done anything with the community garden, but also the food bank. And so we advertise through the food bank. We provide recipes to the food bank that tie in fresh, frozen, and canned vegetables. We work with our local SNAP agency, and we work with our WIC department to try to encourage people to sign up for our prescription produce program that are eligible. We also started partnering with a local organization called Bethel Community Services Foundation. They were given funds through the CARES Act to distribute food during the height of COVID and distributed an insane amount of food. It was not necessarily fresh, frozen, or canned vegetables, but it was what people were asking for in the communities. And so they had this great experience distributing food and working with community stores and working with the individuals in the villages and the communities to provide the food. And so we tapped into their experience and were able to bring them into our prescription produce program, and now they help us with the voucher distribution. And they help us, they've helped us to incorporate more partners because they've had experience working with more stores than we have. They even have helped us to be able to offer prescription produce boxes. So when we first started our program, we had about 8 communities that were on board, and that was out of YK has 58 communities. And so when we started, we had 8, and that was because we were able to get signed memorandums of agreement from 8 village stores. One was Alaska Commercial, which was kind of easy there in Bethel. But then we had a few smaller native stores or village stores that we were able to partner with. We had trouble getting additional partners on board, but when we brought BCSF into the mix, they had such positive experience with working through the CARES Act funds that the stores have been excited to continue to partner with BCSF and continue to try to help to execute this prescription produce program. And so now people have more choices for where they can redeem their vouchers, which is huge, and we wouldn't have been able to have the bigger reach that we've had if we didn't have great partners. So with any partnership, it's important to be able to maintain that partnership, whether that's with the store, whether that's with vendors, whether it's with even your participants in the program. And so you want to make sure that you're fostering or watering that partnership and making sure that you have open lines of communication, that you seek feedback from your partners and you provide them feedback. It may even be helpful to identify and promote program champions. And so we've had some stores that have been really great with assisting participants in redeeming their vouchers, and being able to share that information with the region has been helpful. And then also providing ongoing training and technical assistance. So it's not a straightforward process. Our participants get a voucher. They know that they can take it to the store and they can purchase things. Our voucher, like I showed you earlier, says, it's for fresh, frozen, or canned WIC-approved items. Well, sometimes people manage to purchase things that they're not supposed to. And so it's important that we keep those lines of communication open with the stores, and we can provide feedback and say, hey, just a friendly reminder, people aren't allowed to purchase juice with our vouchers or other unapproved items. And so keeping that communication and providing ongoing training is really important, especially in rural communities. Just like in rural healthcare, there's high turnover rates. And so even in the stores, there's high turnover rates. And I find that new store clerks often struggle with what to do with these vouchers. I've had the experience of being behind somebody at the local AC trying to redeem their voucher, and it was fun. I just kind of stood there and watched. But the store clerk, got out their binder, and it had instructions, and they did all the things that they were supposed to. It probably took a little bit longer than maybe the purchaser would have preferred, but they had their instructions, and they made it through. But it was interesting to have that experience. So I covered this mostly already, but it's something really important to think about too. What's going to be a worthwhile dose for your prescription? We picked $45. We didn't really have a good basis on why we picked $45, but in the years that have come, we've realized that more would be helpful. You guys definitely identified that cost of produce is a huge barrier, and so is $45 enough for your community? Could be. Maybe it depends on how many people are in the household, and so if you are having participants sign up that lives in a larger household, maybe you're able to even provide a larger dose for that type of household. It matters how long the participants are going to be in the program. Our USDA Schumacher Nutrition Incentive Program grant is a 3-year grant, and so we have 3 years to spend all of the funds. Whereas the prescription produce pilot program that IHS offered was actually annual. And so if you were awarded $500,000, you had 1 year to spend $500,000. So you could have either had more participants or offered a higher dose, but these things depend on your funding source. And then, of course, thinking about how often should participants receive their prescriptions, and even how are they going to receive their prescriptions. I was talking to somebody about our program the other day, and they wanted to know if we had participants come in to get their vouchers at a clinic appointment. And that would be great. You have a once-a-month opportunity to interact with somebody, make sure they've had their foot exam, make sure they've had their A1C in 3 months, provide them with some nutrition education or exercise education once a month. That'd be great for us. But is the participant going to come? That's a big burden, especially if they're not local or don't have a car or have to take a plane. It does not make sense for our program to have people be required to come in to see us monthly. But thinking about that and trying to design your program for what's going to work for the participant is really important. You want to make sure that you're maintaining participants too. So you don't want to sign up a bunch of people and then have a huge attrition rate because there were more barriers that the program implemented than solved. So prescription redemption, again, something to think about. I think we have a Kahoot. Ooh, let's see. All right, let's try this. What's available? What can you routinely buy in in the communities you serve? Ann and I were talking about this yesterday. She said cabbage would come up. Potatoes, onions, carrots, most fruits and veggies, canned or frozen, greens, great. This is important though. I think knowing what is available in your community, whether it is fresh or if it's limited to canned or frozen, is really important. When I was writing one of our latest grant applications, I actually did a brief survey of our community health aides that were in town for training. And ask them, what's on the shelf? What's fresh that you can buy? I think there were 5 community health aides in the room, and they represented several different villages. Most of them said nothing. There was nothing fresh, or nothing fresh that they wanted to buy, because if there were bananas, by the time they hit the shelf or moments after they hit the shelf, they're brown and gross looking. I've seen onions in a lot of the villages I've traveled to, but half the time it's got a large mold spot on it. And so really trying to figure out what's available in your communities is important, especially when designing what can people purchase. Let's do another one. Is there access to a farmer's market? Or is there somebody that you could persuade to even set up a farmer's market? Sometimes. That's cool. I didn't expect actually to see such a resounding answer for sometimes. That may be one of those things that you learn, too, in trying to establish partnerships and trying to explore what is available in your communities. I actually heard there's a farmer's market that operates out of Antioch. They have access to daily flights from Anchorage, and so they will ship fresh produce in, and then they have the Antioch Community Market where they offer produce, and they've worked to try to either offer it at reduced cost or no cost to elders. But they've actually signed up and agreed to be partners with us too, so that people can use their prescription produce vouchers at the Antioch Community Market for fresh produce. And they do that through D. Tomaso's. So D. Tomaso's will ship from Anchorage out to Antioch, and then they offer a community market in that village. Next, Kahoot. Is there access to canned fruits and vegetables? Good. So most of you said all the time. That makes sense, right? If you've shopped in a village store or walked in a village store, there's tons of canned vegetables. Not always ideal what they have, but there's tons of it, which probably tells you, too, that people don't often purchase them. But why do they not purchase them? Is it because of cost? Is it because they don't know what to do with them? Or is it because it's not as convenient as some of the other foods that you can purchase in the store? But just knowing what is available is helpful in designing your program. Next one. Is there access to frozen fruits and vegetables? All the time, sometimes. Interesting answer, too. Again, knowing that is helpful, and if you can incorporate that into what people are able to purchase with their vouchers, that's an increased opportunity for people to increase their fruit and vegetable consumption. Let's do slides. Okay, so what can be purchased based on what's available? How will the prescriptions be redeemed? That's something that depends on your partners and partnerships as well. Like I told you, we use paper vouchers, and then we rely on the stores to collect the vouchers and then send them back to us with an itemized receipt of all the items that were purchased. It would be amazing if there was an electronic option, which I think we all know that SNAP and WIC have electronic options, not even options. They use electronic means to use their benefits. And so there's actually a nationwide group that worked on a paper to present to different vendors in hopes of developing some electronic means of allowing for prescription produce redemption. So the days of paper may be numbered. Paper vouchers are challenging. For a variety of reasons. People lose them, people don't read the dates on them. There's nothing holding the stores to accurately, ringing them up right. But they're a means and they work. It would be great if there were electronic options. If you have access to bigger name stores, I'm sure it can be done. I know there's a prescription produce program out of Virginia that works with Giant grocery store, which is near to my heart. It's where I started in high school as a pharmacy technician, and so I think it's cool that they actually use the pharmacy and their electronic cards to do their prescription produce vouchers. And then tracking appropriate purchases. If we had electronic options, that would be easier. But like I said, the stores send us itemized receipts, and we do review them when processing them for payment to make sure that appropriate things were purchased. But knowing how that's going to work or thinking through that before you start the process is an important detail. Keep wanting to tell you, next slide. Participant enrollment. So who's eligible? We touched on this briefly too. Who's eligible? That can be unique to your specific patient population. Who do you want to reach? Do you want to target children? Do you want to target people that have obesity? Do you want to target diabetes? Maybe you want to do something for people with hypertension. But based on funding, you can kind of flex that to what works for your community. We actually have a grant that we were just awarded that's targeting people that screen positive for food insecurity and have Medicaid. We haven't embarked on that one yet, but there is actually codes, ICD-10 codes available that people can have a diagnosis of food insecurity. And so if we can get people screened for that and identify as positive for that diagnosis, then we can work to enroll them in our program. Thinking about who is responsible for enrollment and how that enrollment will take place is kind of a tricky thing too. So when we first did our pilot program, we just had people fill out a paper and say, you know, their name, their birthday, their village. At some point we started collecting their demographics because our funding was SDPI, and so we were only allowed to provide food for people that are American Indian or Alaska Native. With our current program, we kind of have two tracks. So because our program is considered research with the way that we collect our surveys, we actually have to have people complete a city certificate to fully enroll people in the research program. We're able to enroll people not in research by just filling out the form, and it's an easy either paper form or we can email it to people. We also made it available electronically that people can e-sign. But knowing who's going to be responsible for that enrollment and if there's anything specific to how people are enrolled is a key part of the program too. And then thinking about, again, like I said, what information is required. So our original form under the grant was just name, maybe village and phone number. And then we realized we needed more information. So now we collect name, birth date, village, phone number, and a date. And it's okay, you know, to make changes along the way too. It's not a perfect process, and there's always room for improvement. So working through that and being open to working through those challenges is a key to success. So prescription tracking. With the voucher process, it's a little bit tricky, but for our grant, we are required to report the number of vouchers that were distributed. We report monthly and annually. I'm smiling at Karen, who was helping work on this last week. But we report monthly and quarterly the number of vouchers that were distributed, the number of vouchers that were redeemed. And then that differs from the number of dollars that were distributed and the number of dollars that were redeemed, because not always do people spend the full $45. We could track what foods people purchase, and I think that would be a really cool thing to try to track. Anecdotally, like I've noticed, some people prefer to buy 25-pound bags of frozen fruit. Some people will buy canned items. Some people do buy fresh, and I think at some point it would be amazing to collect all that data and really turn that into what do people want, which would help us kind of even more so tailor our program to what meets the needs of the community. Vendors, we track which vendors people are using. The grant wants to know which stores are being utilized. They want to know even the hours of the store and how many days per month the store is open. And then also tracking participant enrollment. So it's important to know how many people are currently enrolled versus how many people have dropped out. And so having a way to track that is useful. So for program evaluation, there are several different parts of it. Monitoring for quality improvement, being able to report on the impact of the program. You can utilize program evaluation to try to recruit additional partners. And so having data on how many people we have in a certain community has helped us bring more partners on board. Funding requirements, so some funding requirements include program evaluation, and we are required to collect surveys on people. The surveys we were able to design, there were certain ones that had to be asked per the grantor, but then we were able to also have our own input on what's included. And then you can also use your program evaluation to leverage future funding. So any program needs evaluation. It helps you know what's going well, what's not going well. It also helps you advocate. It also helps you even show participants why this program has been great. And so since GusNIP first started in 2019, the grantees have increased exponentially, and the data that's come out of these programs has been amazing to help continue to advocate for future funding. And so while it's tedious at times to collect all the data, it really does have an impact. Surveys. My notes are not on my slides, so I'm going to try and get the 6 W's and 1 H right. Who, what, when, where, why, another W, and a how. But who's completing the survey? Where can they complete the survey? When do they complete it? How often? Is it on paper? Is it electronic? These are things to think about when you're designing your survey and making sure you can execute the survey process. And just last thing, just for kind of bringing it full circle and helping you think through the process of what the flow of a prescription produce program looks like. After you have funding or found a way to fund it, then you're going to work through the patient eligibility, a referral from a healthcare provider, creating that actual prescription produce, giving them the voucher, the participant then redeeming it at their prescription produce site. Most programs encourage nutrition education, and so having a way to incorporate that into your program is part of the process, and then of course the data collection. Do we have one more Kahoot? 2 more. Let's do 2 more Kahoots. Does your community have access to produce by mail? Could have done this one earlier, but works now too. And have you thought about using produce by mail? Oh, cool. Okay. A lot of you must use Full Circle Farm or something else similar. That's really cool. We'll save the last Kahoot for 1 more minute, so one more slide. Okay, so I'm standing up here telling you today about a prescription produce program. I told you a little bit about ours, but really I wanted to talk to you about what it takes to start one and really hopefully inspire you to believe that you can start one. And so my call to action for all of you is to identify funding. Think about a target population. Think about some partners that exist in your community. And then think about what goals you might want to address with your prescription produce program. Last Kahoot. Are you interested in starting a prescription produce program in your community? Yay! Good answers. Only one person said, I don't think it would work where I live. Let me tell you, Bethel is challenging, so I don't know who you are. I'd be happy to tell you and convince you otherwise. If we can do it in Bethel, it could probably happen in most other places in the country. And one last slide for cuteness. I was stuck yesterday trying to find a picture for the last slide, and Anne Fleetwood gave me a lovely one of her handsome son, Ren, with his pepper, and then my daughter, Gretchen, helped harvest some potatoes out of our community garden this year and had a lot of fun getting her hands dirty through gloves. Thank you. What questions do you guys have? Jay, you make me laugh.
I've got a question over here. Thank you so much, Beth. I have kind of a functional question about the vouchers, and I apologize for the way I sound. But I'm wondering if the way you designed the vouchers, if they have to be used all in one go, or if there's kind of like a balance left and how you navigate that at the store.
Sure, that's a good question. So we send out 3 vouchers at a time. They're dated for a specific month, but they are an all or none. So if they don't spend the $45 because they're paper, there's no way to like assign a remainder value to them that people could come back at a later time and redeem them. And then if they exceed the $45, then the participant is responsible for covering that additional cost.
So you mentioned that you had targeted your diabetes population who have Medicaid. So if a person has diabetes, but they also have a large family, how does that figure into your voucher and what you provide to them?
So with our current funding, with Gus Schumacher, we can't flex that. They get $45, and then if they share it with their family, they share it with their family. That's actually in the survey that we collect, is how many people are in your household, which is interesting information to look at for how many people that $45 could potentially be helping. With our food insecurity funding that we received, we plan to flex it based on household size, and so then we could give people more vouchers or a higher voucher amount based on their household size.
So I saw that you had a referral or a prescription in Cerner built. Does that mean you also get referrals in Cerner from providers?
We do not have a referral in Cerner for the program. We could, but we actually do a lot of our own enrollment and recruiting. So we've worked with a case management team that has helped us kind of put together lists of people that aren't currently in the program, and they contact them to try to get them enrolled. But no, we don't have a referral. We could, but because they have to have Medicaid, they have to have diabetes, and then when we originally got started, it was only like a handful of communities that people lived in that we could enroll people from. We didn't make a referral in Cerner.
In what capacity or how do you incorporate traditional foods into your program?
Our program hasn't been able to do that, but it's something. There's more and more American Indian, Alaska Native communities that are receiving funds through Gus Schumacher, and it's been a big discussion about how programs can do that. So we don't have, to my knowledge, any availability to purchase like sourdough or dandelion or lavender tea that people could purchase with that. It would be great to incorporate it, but currently we don't offer that. Some programs do, and actually the technical advisor for Gus Schumacher for our program is Kelly Begay, who was a longtime dietitian with the SDPI program, and so she's been really had a lot of insight and information for programs that are looking to do that type of thing. So ours doesn't, but others do.
Got another one.
Have you had any resistance from any of the school or the stores for like the fact that you're having them paid act?
That's been a challenge. We rely on the stores sending us the vouchers in a timely fashion. And last week we were processing vouchers from 2022 because the store hadn't sent them to us. And so they were like, we need paid for this right now because it's, more than a year ago, and otherwise we don't want to participate. And so we try to, foster that relationship as best we can, and once we get them, process them as soon as possible. We have not had any stores stop participating, which I would say is a positive.
I have a question concerning the price that you were discussing and had on some of the slides. How do you determine the price when the prices vary so widely from community to community?
We didn't have a good, well, you know what, we did. So when we did our first program, our pilot in 2019, we worked with Myers Farm, and Myers Farm sometimes grows produce locally and sometimes sources it from elsewhere and sends it. But he had advised us, like, he could make us a good $45 box, which was kind of within our price point in terms of what we thought was reasonable, and it included cabbage, carrots, onions, a handful of apples and oranges. And so we used that as kind of our basis for how we picked $45. And looking at the receipts, it is interesting. People are able to get a fair bit of stuff for $45. Now, if they buy a 25-pound bag of frozen berries, they're probably getting one. And it would be great then to have that data that you could go back and educate that participant on, this is all you were able to get with $45, and could we talk about changing something else? Another way that we came up with the amount, we had a dietitian a few years ago who went shopping at AC and purchased like a pizza and a 12-pack of Coke and maybe a bag of chips, and spent, at the time, I think $30. And then she shopped and bought celery, potatoes, a whole bunch of other things for the same amount. And we used those as educational tools too with people, which was really kind of eye-opening, and we still have them posted in our department that we can use those for educational tools. And so that helped guide, what would be a reasonable amount as well.
You gonna be here all week?
I'm good.
Yeah. So I love Beth's passion for the prescription produce program. I'm sure she's going to be here the next 2 days of the conference if you want to pick her brain some more. So we are at our break for